Hello and welcome to the second lecture in the Neurological Dysfunction series, Increased Intracranial Pressure. The cranial vault is composed of three primary components: brain, blood, and CSF. These components are essential in understanding increased intracranial pressure, and the relationship between these components is well described by the Monro-Kellie Doctrine. This doctrine states that an increase in one component leads to a decrease in another component because there's only so much space in the cranial vault. Whenever a decrease in the second component cannot occur, increased intracranial pressure results. Think of this like packing a suitcase. Only so much can fit into the suitcase. At some point, you must take out some of the components inside of the suitcase, or in other words, the cranial vault, in order to provide room for another component. There are different things to think about in relation to these three components. First of all, with blood, you can associate this with aneurysms, arteriovenous malformations, hemorrhagic cerebrovascular accidents, hematomas, and subarachnoid hemorrhage. With brain, think tumor, trauma, abscess, or cerebral edema. With CSF, think in terms of increased volume, as with hydrocephalus, or decreased reabsorption, as occurs with meningitis, subarachnoid hemorrhage, or obstruction from a tumor or position. All of these things I've mentioned are situations that increase the respective component. This equation shows us that cerebral compliance is determined by a change in volume or pressure. Pressure and volume are inversely related. Therefore, if you increase pressure, you will decrease volume, or if you increase volume, you will decrease pressure. This provides another way to think about the Monro-Kellie Doctrine. This equation can also be plotted on a graph, giving us a pressure-volume curve. This curve tells us that as compensatory reserves are exhausted, compliance begins to fail. In line with the Monro-Kellie Doctrine, if you continually increase volume, you must decrease pressure. But, as you can imagine, you can only take this so far before we run into problems. On this graph, there are three zones. In zone 1, a small change in pressure results in a small change in volume, and there's good compensatory reserve. In zone 2, compliance begins to fail due to a reducing compensatory reserve. In zone 3, a small change in volume causes a large change in pressure. At this point, irreversible increased intracranial pressure can occur with loss of regulatory or compensatory mechanisms. Another concept to keep in mind is that of autoregulation. This is the brain's ability to change the diameter of its blood vessels to maintain a constant cerebral blood flow, or cerebral perfusion pressure, during alterations in systemic blood pressure, or mean arterial pressure. Autoregulation fails when the mean arterial pressure is less than 60 or greater than 150. Cerebral perfusion pressure is the net pressure gradient that allows for cerebral blood flow to the brain. This can be calculated by subtracting the intracranial pressure from the mean arterial pressure and is usually in the range of 60 to 80 millimeters of mercury. A decrease in blood pressure or an increase in intracranial pressure will decrease the cerebral perfusion pressure. Putting all of this together, we can begin to visualize some cerebral hemodynamics. Intracranial pressure, which is maintained by the components of the Monro-Kellie Doctrine, and mean arterial pressure, maintained by factors that control the blood vessels or systemic vascular resistance, contributes to cerebral perfusion pressure, which is determined by mean arterial pressure minus the intracranial pressure. This determines cerebral blood flow, which is determined by autoregulatory mechanisms, which then determines cerebral blood volume, which is the amount of blood in the cranial vault, averaging around 10% of the total volume. Let's look at just a few more factors that will alter the cerebral perfusion pressure. Cerebral perfusion pressure is proportional to the PaCO2 until it reaches greater than 90 millimeters of mercury. In general, an increase in PaCO2 results in vasodilation which increases cerebral blood flow. A decrease in PaCO2 will produce vasoconstriction, resulting in a decreased cerebral blood flow. This mechanism supports the management principle of permissive hypercapnia and increased intracranial pressure. In a similar vein, hypoxemia increases the cerebral perfusion pressure only when the PaO2 is less than 50 millimeters of mercury. The first sign of increasing intracranial pressure is altered level of consciousness. That's why it's so important to assess level of consciousness as an indicator for neurological changes. Later, you'll begin to see vasomotor and respiratory changes. Finally, as this progresses, you may see decorticate or decerebrate posturing, and pupils may become fixed and dilated. The image on the right shows papilledema, a common occurrence in increased intracranial pressure. This presents as blurring of the optic disc margins. By far, the most ominous finding in increased intracranial pressure is Cushing's Triad. This signifies impending herniation, which we'll look at in a future slide. So increased intracranial pressure results in decreased cerebral blood flow, resulting in decreased cerebral perfusion pressure, resulting in Cushing's Triad. This includes hypertension, bradycardia, and bradypnea. Hypertension functions as a compensatory mechanism because an increase in blood pressure or mean arterial pressure results in an increase in cerebral blood flow and thus an increase in cerebral perfusion pressure. The pulse pressure here will widen. However, it's important to note that there's cessation of cerebral blood flow when the mean arterial pressure is equivalent to the intracranial pressure. Bradycardia is another compensatory mechanism. Whenever you slow the heart rate, there's more time to fill the ventricles. This results in an increased preload, thereby an increased cardiac output, resulting in an increased cerebral blood flow and increased cerebral perfusion pressure. Bradypnea occurs in order to increase the PaCO2, as we discussed before, resulting in cerebral vasodilation, and therefore increased cerebral blood flow and cerebral perfusion pressure. I have some CTs that will show a few different underlying etiologies of increased intracranial pressure. Normally, on a CT, the ventricles appear dark. In this case, you can see a whitening of the areas within the ventricles. This patient's experiencing an intraventricular hemorrhage. I like using these images because it gives us a better idea of this abstract phenomenon. According to Monro-Kellie, when you increase blood within the ventricles, there must be a decrease in CSF in order to balance. However, the ventricles take up a finite space in comparison with the cranial vault. As you could imagine, a small change in volume here can result in a large change in pressure. This image shows a cerebral edema. Normally, you can visualize the sulci and gyri on a CT. In this CT, you can see the progression of cerebral edema to the point that it's causing a midline shift in the far right. There are several ways that intracranial pressure can be monitored. These include the ventriculostomy, an intraparenchymal catheter, a subdural catheter, and a subdural bolt. By far the most commonly used in practice is the ventriculostomy. This is a catheter that goes in and rests within the ventricle. With intracranial pressure monitoring, you'll see these different waveforms. An A wave is referred to as a plateau, and it indicates cerebral ischemia. A B wave indicates intracranial hypertension and variations in the respiratory cycle. The C wave is related to variations in systemic arterial pressure. Two of the most common complications of increased intracranial pressure is diabetes insipidus and SIADH. I provided this slide from a previous semester just as a recap. One of the most unfortunate consequences of increased intracranial pressure is herniation. In herniation, there's a shift of brain tissue from an area of high pressure to an area of low pressure. This exerts pressure onto the area in which it's shifted, which interferes with blood supply to that area. Cessation of cerebral blood flow results in cerebral ischemia, infarction, and ultimately brain death. In terms of management, you'll want to monitor intracranial pressure and cerebral oxygenation using monitoring devices and analyzing waveforms. You can decrease cerebral edema through osmotic diuretics such as mannitol, which pulls fluid from the brain into the vasculature and then is excreted by the kidneys. Monitor I&O, the serum osmolality, and maintain a fluid restriction. If there's a tumor, steroids such as dexamethasone may decrease the mass effect. Maintain a cerebral perfusion pressure greater than 70 millimeters of mercury. You can do this by manipulating the cardiac output via IV fluids or inotropes such as dobutamine or milrinone and norepinephrine. Decrease cerebrospinal fluid and intracranial blood volume by the use of a drain via ventriculostomy. This should be used cautiously due to ventricular collapse and herniation. It's also important to control for fevers using antipyretics, hypothermia blankets, and monitoring the temperature. Avoid shivering due to the increase in oxygen consumption. Maintain the patient's oxygenation and decrease metabolic demand. Monitor the oxygen saturation and ABG trend. Barbiturates or sedation may be used here. In these last two slides, I provided a table that breaks down some of the additional interventions that can be used in increased intracranial pressure.